This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I bring you my conversation with Ellen Taylor, where we discuss vascular flow limitations and whether it's advisable to manipulate patients with neck pain, headache, and or orofacial symptoms. Throughout our discussion, we explore the role of PTs in treating these conditions. We also cover how to recognize the risk of serious adverse events before and after manual therapy, as well as how to identify abnormal signs and symptoms. We discuss techniques that require caution, the importance of manual therapists taking blood pressure measurements, and whether they should test cranial nerves. Ellen also highlights the possibility of flow limitations occurring even in the absence of observable vascular pathology and discusses clinical tests to identify these flow limitations, among many other insights. Ellen is a physiotherapist and full-time assistant professor at the University of Nottingham. He has a special interest in sport manual therapy and clinical reasoning, with particular emphasis on vascular issues, haemodynamics, and risk assessment in the cervical spine. He has written 6 book chapters and over 30 peer-reviewed articles and lectures worldwide. Additionally, he serves as an expert witness in cases involving altered haemodynamics and clinical negligence. If you find this conversation interesting, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with other clinicians who could benefit from this conversation. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Hi Ellen, welcome to PT Pro Talk. How are you today?
Hello, and thanks for welcoming me. I'm very good, thank you. It's a nice warm day in England and we're enjoying the sunshine for a change.
Awesome. So let's get started talking a little bit about yourself and your background for the ones that don't know you yet.
Okay, I'm a physiotherapist by trade. I currently work as a university professor or lecturer. I've been a physiotherapist for quite a long time. I had a specific interest in vascular issues that relate back to my master's degree many years ago, where I did a study on athletes who had vascular flow limitations affecting the lower limb, which initially were masquerading as sort of symptoms of sciatica. So they were presenting with leg pain. It looked a lot like sciatica. The patients had been told that it got trapped nerves and various things like that. And out of seeing one particular patient, I developed a study and we looked at this. And then from that, I guess my interest developed into blood flow generally and how, even though as physiotherapists, I suppose from a massage perspective, that's where the profession started. It was around blood flow. But we've kind of forgotten lots about blood flow, and we're not taught that much about blood flow at undergraduate level. So I thought it was a really interesting area, which I personally didn't have much grounding in. So I've developed over the years many different sort of papers and book chapters which have sort of addressed that sort of, what shall we say, deficit in the knowledge, I think.
Yes, that's great. And so we know that sometimes neck pain, headache, orofacial symptoms can potentially be the first non-ischemic, right, symptoms of underlying vascular pathology or blood flow limitation. So in your opinion, so what is the role of us physical therapists when treating these patients?
Well, The other thing that I didn't mention, part of my role is also to work as a medico-legal expert witness. And one of the things I've learned from doing that is that it's not just about the treatment of patients, it can also be about the assessment of patients. So basically, a patient walks through our door, and we then have the responsibility to be able to do an assessment that will allow them to safely walk out of the door and be managed in the correct way. And I think that's the way to think about it. So I think less about the dangers perhaps of some of the treatments, although I consider them. I just think about how the whole thing looks as a big picture. So one of the things that we do know is that headache, neck pain, orofacial symptoms, jaw pain, that sort of thing, or various facial pains, can be a manifestation of vascular problems. So with that simple knowledge, if someone comes in complaining of those things, then I think it's our duty to do a really, really careful examination and sensible examination, which may or may not need to be altered according to what our suspicions are. So because we have a desire to maybe do range of motion things, that might come quite early in an examination. But in actual fact, if you've got a high suspicion from the subjective history that the patient's been giving you, it may be that you have to change your order of your physical examination and maybe leave things like range of motion and then palpation and lots of other things that you would like to do normally, probably till later on, until you've done some of the more, what I would call, safety parts of the examination.
And so how can we recognize the risk of these serious adverse events before and after treating our patients?
I don't think this is easy. And I think the first part of this is just simply to recognize that these types of symptoms will manifest. And what we can have when someone comes into the clinic with a headache and possibly a neck pain and other attendant symptoms like maybe dizziness or something like that, what we can have at that point is a patient who's walking through the door who already has some kind of vascular disorder. So they could have a pre-existing dissection of an artery, which doesn't have to be traumatic. It can be non-traumatic. Or they could have the very early stages of the presentation of a stroke. Okay, so that's the first part. And then the second part is recognizing that we need to probably look at different examination strategies. And we've written about this, I've written about this with various authors over the years. If someone's got headache and neck pain, I think one of the first go-to areas is that we've most certainly got to look at assessing the cranial nerves. Because in every other area of the body, if we suspect someone's got a neural involvement in the lower limb, if we suspect someone's got a neural involvement in the upper limb, we'll only do that based on symptoms. And the symptoms most likely that will lead us to that are tingling, pins and needles, and maybe some motor dysfunction. Weirdly and strangely, I don't know what it's like where you did your training, but certainly over here in the UK, we don't think the same way about the symptoms that go upwards towards the head and neck. And there's been a reluctance for some reason for cranial nerves to be taught and for cranial nerve testing to be performed. And I've always puzzled over why that is. But based on the fact that if someone has got these symptoms affecting the head and neck, we've got a very high risk situation. The question for me is, why wouldn't you assess the cranial nerves? Because it seems like a really logical thing to do, the same way that you would assess the lower limb nerves and the upper limb nerves if you had that suspicion. The only difference is this is a much more serious affair, because if we do have a problem with the vascular system and maybe the cranial nerves combined, then this could be the development of a serious condition.
Yeah, I just remember hearing about them and studying their function, and that's it. We don't learn how to assess them, do the tests.
No, and I think there's that. And there's also, it's not about how, it's why. I mean, for me, the question is why? And the answer to that is because someone is coming in with some symptoms that look like they could be neural or neurovascular in origin. Therefore, And that can just be the distribution of the pain, for example. That could be enough. And they may have other attendant symptoms like numbness or tingling or, other things like dizziness. And we can go further than that. And some people will have developed dysarthria by the time they come in. And by then it's becoming ischemic. But often it's much more subtle. And there's a really strong indication for taking cranial nerve tests.
And I think you have a blog where you have like a series of videos talking about that, the assessment of the nerves.
Yeah.
And also a paper, right?
Yes. The team that I've been working with, that's myself, Roger, Nathan and Ferras and various others, did put a nice paper together that, which I can't remember the title of off the top of my head now, but which is about the assessment of cranial nerves for clinicians, yeah. So that is a nice paper, and it sort of details also some of the subjective things that you might want to be asking about cranial nerves, difficulty with swallowing, et cetera, and all the subjective stuff before we even get into the actual logistics of the cranial nerve testing. And it also explains the significance of why you might be doing that related to what the anatomy of the cranial nerves is and which cranial nerves might be affected.
Yeah, I just wanted to mention so people can go look for these resources, because I think it was very nice and easy to understand to help us do that in our practices. So that's very
I think
helpful.
That's one of my favorite papers that we did. I'm just trying to look for the actual. Oh, there it is. Assessing the cranial nerves in physical therapy practice. That's one of them. And then there's also a guide to cranial nerve testing for musculoskeletal clinicians. And that's probably the one. That was 2021 in the Journal of Manual and Manipulative Therapy. And that was myself, Firas Murad, Roger Kerry and Nathan Hutting. And that goes into lots and lots of details, lots of nice diagrams and all the rest of the stuff that goes with it to sort of guide clinicians about really how and why they ought to be sort of incorporating that into their clinical practice.
Yeah, and you have that, I was looking for the name of the blog that I saw. It's author haemodynamics.blogspot.com, right?
Mm-hmm.
So they have like short videos there too.
Yeah, it's been a while since I've written in that blog. I've been a little bit less productive on the blog and perhaps the Twitter or X side recently, but there's certainly some stuff in there. And I've also there's some stuff on a YouTube channel where there's a few videos talking about simple cases that allow you to sort of do a little bit of clinical reasoning. So I think the message is what we've got to do is just incorporate this into our clinical reasoning. So if at the start of the process you haven't even got vascular or neurovascular on your radar, it's unlikely to come into your thinking with regard to why the patient's got those particular symptoms. I think 9 times out of 10, you'll probably discount the vascular hypothesis and get on with what you're doing and carry on with your normal assessment. But the other thing, and I don't know whether you've got a question about this later, but I might go here now. The other thing that goes with that assessment is, and for me, I learned this from a patient. In fact, I learned nearly all of this from patients. The very, very beginning of this was a patient who came in with leg pain, and I couldn't make sense of why he got this leg pain. It was a young athlete, and eventually it was a very real description. And at the end of the day, instead of doubting the patient, I started to doubt my own knowledge about why I couldn't work out what was wrong with this patient. And then after discussion with various people, we decided to look at some vascular options, which wasn't on my radar at the time. This is many, many years ago. And it turned out that this young 31-year-old athlete had got quite a severe advanced lower limb vascular problem. And that made me realize that, we just have to have these things on our radar. And I think that's really useful. And if that's your starting point, then you're always going to have. And I always say, think of the worst case scenario, because in actual fact, if you're saying to yourself, oh, well, could this be vascular? And then you go through all the tests that you might do. And I'm going to talk about blood pressure in a minute. And it finds all the cranial nerves are okay, the blood pressure is okay, and all the rest of the stuff appears okay. Then you can probably proceed with caution at that point. And then maybe go through your normal assessment and management and see how things go, and then consider safety netting the patient. with regard to whether they get worse or better or what happens to the symptoms. But the other part of the examination, and this is the bit I learned from the patient. I always remember a patient coming in to see me after a whiplash injury. And she'd got these really odd symptoms, and she'd also got an asymmetrical face. And this is before I got into all this cranial nerve stuff. And I was thinking, this is really odd. And, it's not the sort of question you can ask, do you always look like that? It's something, you just wouldn't ask. And I was looking at this lady's face, and she was telling me, she was a physiotherapist, actually. She was telling me all this history, and I was listening to it. And then at one point she said to me, Alan, she said, sometimes I feel like a ticking time bomb waiting to go off. And at that point, I thought to myself, this is a bit odd. And I always say from then on and always really listen to what the patients are telling you. So I was in the sort of hospital clinic at the time, and I thought, I think I'm going to go off and get the blood pressure monitor. So I went off down the corridor, got the blood pressure monitor. I took this lady's blood pressure, and it was off the scale. It was 220 over 130 or something like that. Yeah, which was, a dangerous blood pressure. So in actual fact, what she said was quite right. She was a ticking time bomb waiting to go off. It was a story with a happy ending. She lived to tell the tale. She didn't have a stroke, and it all got managed, and she lived happily ever after. But of course, if I'd not taken that blood pressure, I might have gone on to do what I normally do, which would be range of motion, various different passive movements, et cetera, and who knows what might have happened then. So I'm always saying to myself personally, based on my clinical experience and what I've read and what I've understood over the years, that I think there's times when we have to consider modifying our usual approach to these odd patients. What I mean by odd patients is patients who describe these odd symptoms, and you start to think, I'm not sure that sounds like the usual thing that I see every day. It sounds slightly different, and I'm not sure I have to approach it. And my thing would always be to go down the safe route, do your cranial nerve testing, take a blood pressure, and then if all of that is fine, then maybe proceed with caution and see how things go. But if, as I've found on numerous occasions, we find an abnormal blood pressure or we've got these abnormal cranial nerve findings, then it's time to refer patients on to the correct place, and fairly soon too.
That's what I was going to ask you, do you had many patients that you did cranial nerve tests that were not normal, and then what did you do?
In general, it depends on the big picture. That it's really about how the patient's presenting. I mean, if the patient's presenting unwell, looking at, sort of abnormal colour, the blood pressure's off the scale, that sort of thing. I'd always be sending those patients to. In the UK, we send them to Accent Emergency, and I guess it's the emergency department. If it's cranial nerves, well, that's different. It depends on the big picture. It depends how the patient's presenting. I mean, if I'm alarmed by a combination of maybe a partially high blood pressure that's not quite off the scale, but I'm also getting some cranial nerve findings too, and then I'm looking at the bigger picture, then I might want to send them to an emergency department. But it might just be that it's not an emergency, and they might just need to go and see their general practitioner and have these tests done at a later time. So that is a judgment call. I think you can only ever do that based on the big picture. And I always say, what's the status of the patient? Are they staying the same? Are they getting better, or are they getting worse? And the ones that are getting worse are more likely to refer quickly. The ones that stay the same, well, maybe they can have a delay before they get attended to.
And regarding the blood pressure, do you always take blood pressure of your patients, or just if you suspect of something?
Great debate, this one. Now, I've been a big advocate for a long time, both in written papers and on social media, that physiotherapists, probably in most settings, ought to be considering whether they take blood pressure just as a basic test. And everybody goes, oh, I haven't got time for all that because I've got all these other important things to do. But I'm kind of saying to myself, well, if you work in manual therapy, I would say it's almost like a no-brainer. If a patient's coming in, you really don't know what their blood pressure is. And I also learned this from patients because I worked in a setting, it was like a gymnasium setting where every single patient that came into the gymnasium had their blood pressure taken as routine. It was part of a medico-legal routine that the gymnasium put in place for safety reasons. And I was astonished at the outcome of these findings. So these fit, healthy-looking individuals that were walking into the gym wanting to start a fitness program, they had their blood pressures taken, and there was a large proportion of them that actually had either pre-hypertension or full-blown hypertension that was picked up at these pre-checks prior to the sort of joining the gym. I thought to myself, well, this is really odd, isn't it? So in actual fact, what we don't know ever when a patient walks in is whether these are patients that are normal or whether they're hypertensive or whether they're really hypertensive. And we can't know by just looking at them. And what we're going to do, we're about to then move them around, do some tests, do some passive tests, and then probably then do some treatments that might involve movement and activity, and then probably prescribe some exercises, and then specific to their condition, if it's a head and neck condition, and then probably prescribe some physical exercise thereafter as part of their management. Now, I'm thinking to myself, if I'm going to do any of those things, I'd probably want to know what a patient's baseline blood pressure is before I started, even if it was just the physical exercise. Because I don't know, should I be starting a patient with a physical exercise program if I don't know what their basic blood pressure is? And I think the answer for me is always yes, we all ought to be taking blood pressure as a routine thing. And the other reason for taking blood pressure is, depending on what environment you're working in as a therapist, many therapists will be seeing other conditions like patients with hip pain, patients with knee pain, lower limb problems, arthritis, etc., etc. And of course, many of those patients will also have an attendant obesity issue going on. And of course, one of the things that we'll be wanting to consider are health interventions and looking at diet and physical activity and all of those things. And I think actually taking a patient's blood pressure is a really nice way to get into that way of thinking about things. And what we call it in the UK here is for clinicians to make every contact count. So for me, I'm saying, well, if I take a blood pressure, I'm probably going to be able to make every contact count, because if I find a blood pressure that's normal, I can reassure the patient that that's good, but we've got some other things we need to look at. We've got to look at, weight, diet, and how that impacts on your arthritic knee or hip, et cetera, et cetera. And, and if the blood pressure is elevated or they've got pre-hypertension, then that's the perfect way to lever into this situation where we can start to talk about patients about their lifestyle. All right. So I'm a very strong advocate that we should be taking blood pressure as a routine sort of data that we do it every just at the beginning of the assessments and maybe intermittently through a patient's progress, because it can change.
Mm-hmm. Yeah, absolutely. And you have to have the basis so you know what you're dealing with. Alan, and then in the beginning, you talked about the pre-existing dissection already, or like the stroke presentation. So like, how can you identify those on the assessment? Because you talked about the different strategies like the cranial nerve. So when you mentioned that first one,
you can't. The answer is I really don't think you can. I think at the end of the day, you're listening to a patient's history. There'll be some alarm bells that might hit you within the history. And I think if someone is presenting with this sort of early manifestation of stroke, you will probably pick it up with either the blood pressure or the cranial nerve testing, but it's not guaranteed. It really isn't guaranteed, and we don't have any method. So the other things that have been done in the past, we've done sort of vertebral artery testing. We know the sensitivity and specificity of that is really poor. And so the recommendations from the IFOMT sort of framework on that was that that's not really a helpful thing to do. All I can say to you is have these things on your radar. Listen to the patients. If they're talking about unusual symptoms that are not making sense to you, that are outside the usual, then listen carefully. Don't think the patients are telling you a tale. It's probably their real story. And apart from that, just do those basic things that you can do. And if you're not sure, you really do just have to go on your best judgment and send the patients off to be checked. If you're uncomfortable in your clinical situation, I'd rather send a patient to be checked than just carry on at that point. And that's as good as it gets. I don't think we have anything else, because all that would happen then is if there was a suspicion and the doctor that was attending the patient thought there was also a suspicion, then they might be sent on for further tests like MRA or CTA, something to look at the arteries or whatever else is suspected could be a cause. But don't forget that even that is not fail-safe, because lots of the vascular problems that we encounter only manifest themselves in specific positions or under specific conditions. So in other words, you could have a patient who might have, let's say, arm symptoms or even vertebral artery symptoms, dizziness, drop attacks, that sort of thing, where we can often only see the manifestation of it when the arm gets elevated into particular positions. So, and the same applies in the lower limb, and the same applies in the cervical spine as well. So in other words, we could take a MRA, a CTA in a neutral posture and just find normal looking vessels. It's only when perhaps they are put into a provocative position that we might find where the problem lies. So even those gold standard tests that they often talk about are not fail-safe unless someone has been put into a provocative position. And I was talking to a patient about this last week who sounds very much like he's got a subclavian steal syndrome, where he's been getting vertebral artery symptoms and also arm symptoms, but his tests had all been done up to that point in neutral. And so the doctor said he's absolutely fine and he couldn't possibly have subclavian steal syndrome. But in actual fact, unless they've done some provocative testing on him, they wouldn't know the answer to that, to be fair. So it's worthwhile looking at the big picture and realizing that movement can affect vessels, and therefore we have to do the appropriate tests for what we're suspecting. And we learned that from the lower limb and the upper limb, and the same applies to the cervical spine.
That is so challenging, because I was just thinking here about like MRIs. When you do MRIs on your back and you are in like neutral position, you also don't see the same as when people are moving. So I was just comparing on my head when you're talking about the vascular. Like when you're moving, things are different than when you're static in that position, getting your exam done.
Yep. I think that's the case. And I think, we look at these scans and think they tell us everything, but in actual fact, maybe not.
Mm-hmm. Yeah. So no reliable clinical tests.
No, you have to go on your clinical reasoning, the big picture, and just putting all the stuff together. And then, you are flying by the seat of your pants, I'm afraid. There is nothing at all out there that we can go and do this, and this will tell you.
Yeah.
And it becomes obvious when, maybe we're starting to see, patients getting dysarthria and those sorts of things, it becomes really obvious then. But we're often seeing these things at pre-ischemic stages, and so it's much, much harder at that point when they might just be presented with pain, just pain. Mm-hmm. There's no perfect answer to this that we've reached yet. And despite the guidance and the frameworks and all the stuff that's been written, no one has the answer to how we solve this issue. We've just got to have it on our radars and be good clinicians and listen to patients. I think that's the best we can do. And then also write in our notes what our suspicions are. That's very important from a medico-legal perspective. And then if you feel uncomfortable or unsure, act on that and do the right thing.
So the subjective history is our best friend so far? Yeah,
I think you've spoken to Nathan Hutting. He's a big fan of subjective history, as am I. And I think it's exploring. I work with a doctor, an A&E doctor in Nottingham called Frank Coffey, and he teaches our master's students. And he says he's an Irishman, and he's got a very strong Irish accent. But he says you've got to listen to what the patients say. Listen to what they've said, and then you've got to question them, and you've got to you've got to search with your questions, and he always calls, do it to death. Do it to death. And what he means by that is just keep searching what they're saying and what they answer until you're really, really sure what they mean by what they've said, and you've got a really good idea about what they're complaining of, and then you can start to then do your clinical reasoning much more clearly. So don't just listen to the description, probe deeper, ask for more, and get more detail and get the patients to really, really tell you what's happening. And sometimes then they start to say things like, oh, it feels like I'm not getting circulation to my leg, my arm, my head, things like that. It's really weird. So if you start to ask them more questions, they begin to tell you exactly what's going on because they literally articulate it for you there and then. They just say, it feels like I'm not getting blood flow to wherever. And you're going, it could be that you're not getting blood flow to this area. But that's what Frank means when he says do it to death. Question them really deeply and get an idea of what and also get an idea of what they think's happening, because sometimes they know.
Yeah, so crazy.
Yeah.
And what would be some things that the patients say that would get your attention, that you would start thinking about something?
It depends which area of the body we're in. I mean, always if we're in the kind of lower limb and probably the upper limb, I tend to think that there's often either an exercise or a movement component to the symptoms. So in other words, in the lower limb, classically, the patients, I mean, for instance, just going to the cyclist that we did in the study, the cyclist would have been able to ride all day at, let's say, 125 beats per minute with no symptoms whatsoever. But as soon as they then got to the point where they had to either go up a hill or sprint, and they got their heart rates up to, let's say, 150 beats per minute, and their maximum was maybe 185, that's when the symptoms would come on at 150 beats per minute, and they'd stay on whilst ever they were above 150 beats per minute. And then as soon as they went down to below that, the symptoms would go again, and they could still keep riding at maybe 140 or 130 beats per minute with no symptoms at all. And that's a classic exercise-induced component, which is telling you need to explore vascular. If there is an exercise, and angina presents the same way. So angina affecting the heart will present the same way. The patients won't have symptoms at rest. They'll walk upstairs, or they'll walk up a slope, or they'll have to run for the bus or whatever, and then the symptoms will come on. So it's under exercise-induced conditions. Now, in the head and neck, and the same happens in the arm, but it usually involves positioning as well. So there are lots of situations where often above 90 degrees, there will be an impingement of the blood vessels. And so often that isn't just exercise, it can be position sort of dictated. In the head and neck, there is an exercise-induced component, believe it or not. You can get jaw claudication, which sometimes happens in giant cell arteritis affecting the arteries of the head, neck, and face. And patients will complain that they get pain, facial pain, when they chew. All right, because the muscles are becoming ischemic, the same as the muscles in the leg were becoming ischemic under those situations that I've just described. That's very rare. So temporal arteritis or giant cell arteritis is very, very rare. But again, anybody who's got headache that's probably over the age of 70 who complains of jaw claudication, your ears should prick up straight away, and you should be thinking, could this be giant cell arteritis? Do I need to get this patient off very quickly and have them tested? And there's a number of tests you can do there. And those things can often be picked up with just simple things like palpation and observation, in actual fact. So that's often very quickly done, but it needs to be on your radar. So a lot of these conditions are not classically taught in physiotherapy at university because they're so rare. But because we treat headaches, we could get a giant cell arteritis walking through our door. So we do have to have it on the radar. I always say, think of all the worst case scenarios first and then go down to your softer things later. And I think we've always thought about it the other way around. We've gone, it's bound to be a joint problem or a muscle problem. And then we'll ask a few red flag questions. I always say no, go the other way around. Go, could this be a stroke? Could it be a temporal arteritis? Could it be something really, really serious happening? Probably not, but let's just test first. And then after that, we'll go to the soft things afterwards. And that would be my approach here.
Yeah. And like their symptoms would be mainly like pain in that case, or depending where the presentation
again, depending on the whereabouts you're in the body, pain. It's not always severe pain. It's discomfort in the lower limb. They'll describe loss of power. So the cyclists that suffered these problems always said that if it was affecting one leg, it felt like they'd lost power in one leg. So maybe pain, discomfort, loss of power, tingling, pins and needles. So stuff that sounds like it's neural. Mm-hmm. And sometimes discoloration perhaps of the limb, but that would need to be quite advanced. But that would be rare. But the main thing is this loss of power in the limb, and that happens in the upper limb as well. If you've got an arterial flow problem in the upper limb, often we can see it in swimmers occasionally where they're doing the sort of front crawl and they're losing power. It's again, it's when the blood flow is not making its way to the limb in the way that's expected. In the cervical spine, because there's less of an exercise-induced component, it's usually just range of motion. So we do know that patients will complain of combinations of rotation, maybe extension that might bring on drop attacks or various things. And that's often where blood vessels that are perhaps not normal in the first place become affected by the movement that takes place, the normal movement that takes place, and then patients can then have an ischemic attack as a result of that. So a drop attack would be a classic one that we often talk about, and they do exist out there.
And then if they are having ischemic symptoms, what would they be in the head?
Well, basically, usually what happens is that if I turn my head that way, I'll probably get a reduction in blood flow on one side or the other anyway, because hopefully the rest of my circulation, circular Willis and everything else, and my carotid arteries all work as a system. Even though I've closed down my vertebrals, I've still got carotids going and I've still got stuff here working. Mm-hmm. It's fine. But in somebody who's got maybe a situation where the system is not working as it should do and they're not getting the blood flow shunting from one place to another, then they might develop these sort of symptoms. So the classic one is Bow-Hunter's syndrome, where normal blood vessels, so non-pathological blood vessels, when they go to the position to do to like Robin Hood did, to pull the arrow, they turn into this sort of position where the head is turned quite far. And there's a lot of muscular activity going on in this sort of area here. And then what happens in some cases is because of an abnormality of a bone or a fibrous band or something in one area or the other, the circulation just shuts down, and then they can either feel faint or actually have a drop attack. So that's the classic one we often see that can affect patients who may have, if they did scans on them, they might have perfectly normal looking blood vessels, but it's only when they get into this sort of extreme position where the muscular activity comes on that we see the blood vessels affected.
Yeah, and it takes me to another question I wanted to ask you. If flow limitations may present in the absence of observable vascular pathology?
Yeah, I mean, this is perhaps a controversial topic, because when IFOMT put out their latest version of their guidance, they talked about, I can't remember what the title of the paper was at the time, but it talked about vascular pathologies, which is fine because lots of things are vascular pathologies and we do need to look for vascular pathologies. But in short, the answer to your question is you can absolutely have a flow limitation problem without any sign of pathology. So that one I've just described to you there, the Bow-Hunter's one, it can have pathology, but often they don't have pathology. And all that happens is there's a mechanical thing that occurs that closes down on the blood vessel when they get into this position. And the same can happen in upper limb. It can also happen in Eagle syndrome, where the styloid process affects a normal vessel. And again, it can impinge on the carotid artery in this case and cause sort of ischemic symptoms. So I think it's a misnomer, or it was unfortunate that IFOMP chose to refer to vascular pathology in that way, because in actual fact, it would be a lot more accurate to talk about vascular flow limitations. Then you can include everything then. You can include the pathologies on one side, then you can include the mechanical reasons for blood flow on the other side. And then put it all together, and that makes much more sense. So I think they've got some work to do still on their next piece, on their next version of this, if you ask me.
Yeah, and like when it's mechanical, so what is the solution? Is just not be in that position, just don't perform the movement? How do you treat that?
Well, it's a good question, and that all depend on your patient. So if there is a mechanical issue, certainly we see that in the lower limb with a lot of elite cyclists developed sort of what they call flow limitations because they got more tortuous blood vessels. And in the end, that's a tough call, because in quite young athletes, what they were doing, they were going in and doing sort of arterial surgeries on these characters, and in some cases shortening the artery so that it didn't kink quite so much. So that would be a fairly serious solution. In the upper limb, maybe, it depends what's causing the issue, but you could have fibrous bands, you could have a cervical rib, you could have any number of things, tight muscles. And again, the solutions can be physical therapy. So these things can be managed by physical therapy, where the therapists look at the tight elements and see if we can do things that might address those. Or perhaps more commonly, if that conservative approach doesn't work, then often the upper limb ones with thoracic outlet syndrome affecting the arteries or the veins will go to some kind of surgery where they'll remove the offending piece of anatomy, whether it be a bone or a fibrous band or a muscle or whatever it is, and hope that will provide a solution to the problem. In the cervical spine, if, as I always call this lady, Mrs. Miggins, is keeping her pepper up in the left-hand top shelf, and each time she goes to reach for the pepper, she has a drop attack, and believe me, that's a true story. Then the answer is to move the pepper down into the lower shelf. She doesn't need to go for a surgery. All we have to do is just get her to realise that any time she puts her head up and turns her head that way, she's going to have one of these drop attacks, so stop doing it. It's that straightforward. So it all depends on the type of patient you're looking at. So some of them are elite athletes with flow limitations due to tortuous arteries, and maybe things like endofibrosis. And then we've got the other end of the scale. We've got the older lady who's got an atherosclerotic systemic problem affecting the carotids and the vertebral arteries. And when she closes one of the arteries off, she then gets a drop attack. She's just got to avoid that. I mean, they'd be very reluctant to want to go to surgery with somebody of that age with that sort of pattern of activity, because mainly she could avoid that entirely by avoiding the positions that will bring it on.
Yeah, the athletes will be a lot harder, because if that's the movement they are performing and they have to keep repeating them, that would be the problem.
Yeah, it is. And, it varies. Some of the athletes have got the problems due to these looped arteries, and some of them have got the problems due to actually developing pathologies. So there's a condition called endofibrosis that affects the lower limb. And there've been a lot of successful surgeries on those athletes, and they have got back to quite a high level. But it's a risky surgery, and they've had some, side effects from those surgeries as well. So I think overall the surgeries have been successful, but they don't come without their risks. Those things, and these are young people, young fit athletes. So it's quite a high risk strategy to go in for surgery, even on those ones. But because they're often professional or Olympic level, they're quite willing to put themselves through those sorts of surgeries to gain the benefits that they like to see.
Yeah, and what are the techniques that we should be careful using with these patients?
So this is still talking about manual therapy techniques, is it? Yeah. Okay. My answer to that is probably, first of all, regardless of your techniques, first of all, your assessment. Because if you've got a high index of suspicion that somebody might have impending stroke, vascular problem of some sort, et cetera, from the subjective history, I would say before we even get to techniques, consider whether you really do need to do full rotation with overpressure on this patient as part of your assessment, and whether you do need to do all of your passive range of motions to the very end of ranges with overpressure, et cetera, et cetera. So regardless of techniques, I'm saying, first of all, examination. And the reason I say that is because the last two medico-legal cases that I looked at here in the UK were not treatment cases, they were assessment cases. So they came to me because a patient had a stroke within a short period of time of leaving the physiotherapist's office. And then I had, as an expert witness, then to look at what they did as their assessment and all through the notes and all the rest of the stuff, and then make a judgment on whether they did what was normal or perhaps what, or whether they could have modified it or not. So that's the first thing. And I guess I don't think we've got enough evidence to tell us one thing or the other. I could get into deep problems here by answering this one. I don't think there's enough evidence to say whether, mid-range techniques, end-range techniques, et cetera, make any difference. I think at the end of the day, you have to have a judgment call. And anyway, I think if your index of suspicion is there and high, you probably would be cautious with all of your techniques anyway, and probably go for what you believe are softer level techniques. There's lots of things we can do without having to do manipulations. And there's many, many things we can use which will give patients relief. So if you're not sure, I wouldn't be using manipulative techniques personally anyway. I'm not saying don't use them. If you're comfortable and you've done all your assessments and you're happy, go ahead and do what you please. But I don't think there's enough evidence out there to say whether it's this technique, that technique, or another technique. I think we could just as easily, what shall we say, leave a patient with a vascular episode from your assessment as you could from a treatment. That's my view on it.
Yeah, and that's so hard, because how you are going to relate that stroke with the treatment that you made, because it could happen anyway. So that's
like I've said, it is so hard because, like I've said really early on in this chat, is that what you could have is somebody who's got the early signs of a stroke walking through your door telling you they've got neck pain and headache. And that's actually your job to try and do your best, even though we haven't got all the tools we might like, to try and make sense of that. And it is hard. I understand it's hard. And, we can argue around this for hours and hours, but there's nobody, I don't believe, on this earth who's got the answer to exactly how you would approach that at this stage. We've got more work to do as therapists. And even with more work, I think it's always going to be a little bit uncertain. I would just exercise caution and have these things on your radar, having read about, there's lots of papers written on these things now. So go and read around the topic and just have it on your radar. Don't get terrified by it, though. That's the other thing, because when you first start reading it, you think, oh, all my patients that come in with headache, they must have something serious going on. That's actually not the case. It really isn't. Most of them really, really don't. There's only a tiny, tiny few that might, but it's those tiny few that end up being medico-legal cases or going on to having, adverse events. And they're rare at the end of the day. These things are really rare. So don't get carried away. You curve. I always say there's a curve when you start looking at the cervical spine where you go, oh, this is really dangerous. And then after a while you go, oh, it's not that dangerous. It's somewhere down here. Yeah. And I think that's where most people end up being with this. But I think you've got to recognize that there is a tiny danger out there. But that said, we are seeing more and more patients with obesity, metabolic problems, and hypertension now. We know this is on the increase. So I think that's another reason we need this on our radars, because of the health of the population. It's not getting better, it's getting worse.
Yeah. And I was just curious to ask you, so how, is it common to have those legal cases? How often do you see them?
In the UK, no, it's not that common. I might see one or two a year. But then there's other people looking at them as well. So I don't know, over a year, who knows, maybe a handful. Yeah. But that's enough. You don't want to be that therapist that gets involved in that. Do we hear about these things in America as well?
I mean, I'm sure a lot more than UK.
Yeah, it just seems to be okay.
I mean, I don't know. I'm just assuming because I think it's more common that people sue each other in America.
Yeah, that's the impression we get.
Yeah, I'm not sure. That's my impression too. Um, so I know you published like a paper, what you look out for, what you do, and when, and you just described 3 cases. Would you be able to just briefly mention them to give us an idea of how it works in practice?
Mariana, no. Well, let me pull this bit out. No, I don't think I'm going to be able to elaborate on those 3 cases because I was going to prepare that tomorrow when I got the time.
No problem.
You
we
cut that
skip
bit out.
that. We skip that for now. And what the safety netting is?
Yeah, safety netting really. It was developed in the UK for patients with suspected cauda equina problems in the first instance, as far as I'm aware. So that's one of the most common sort of red flags that we encounter, perhaps, or we certainly taught that most commonly in physiotherapy. And safety netting really is where we give those patients a card which details the things that they need to look out for, symptom-wise, maybe, and then act upon if those symptoms get worse. In other words, if they get, sort of increasing urinary problems or whatever it might be, then they need to go back quite quickly to the doctor and get them to get it checked out. And it's the same with these vascular problems affecting the cervical spine and head. It's really just detailing on a very short, simple, credit card size card, what the symptoms are that you might want to just look out for. And that would be increasing pain, increasing numbness, dysarthria, those sorts of things, increasing numbness, all of those sorts of things affecting the head neck region. And it allows patients just to have a clearer view of the sorts of things that, might be considered that need acting on sooner rather than later. So that's the safety netting principle, really. You just give them that information and tell them that if this or this begins to develop or get worse, you need to do this. And that's often either go to the doctor quite quickly, or in here, it would be go to accident and emergency or the emergency department. That's it.
It's basically like educating the patients and like what to expect after the session so they know if they have pain, stiffness, headache, dizziness,
Yep.
if you're tired.
Often it's worsening elements of all of those things as well. And also change in the nature of it. So, the headaches becoming, maybe pulsatile or something like that. So, yes, it's educating the patients in a very short, simple way about things that they ought to be on the lookout for. It's a nice thing you can do. So if you've got one of those ones where you've got an index of suspicion, but you're not quite sure, and you do your assessment and they're all okay, everything's fine, but you say, well, actually, because I'm a little bit concerned about some of these symptoms, I'm going to give you this card and then explain to them what's on it and say, well, go, take it home, and if you need to, put it, on the kitchen top somewhere, and if you need to refer to it, if symptoms get worse, go and have a look and then decide what to do.
Yeah, I was thinking about those cases. I just remembered that one of those cases from your paper, the person was like deviating while walking and didn't know that was not supposed to happen. So they were not aware that could be.
Yeah, I think that's a good example. So there's various things that, patients come to physiotherapists or physical therapists because they think they've got a musculoskeletal condition. And they often don't put together some of the neurovascular symptoms that they're experiencing alongside the pain or their stiffness or whatever else they've got. And that's a classic example of, if a patient starts to develop, abnormalities of gait or whatever it might be, that's something that they ought to look at. Or, facial asymmetry is a classic one. It's like that one I described earlier. That lady did have a bona fide, sort of some cranial nerve problems at that time, which settled down over time. She was fine in the end.
Okay, very good. Ellen, I know we have discussed a lot of things and can potentially discuss a lot more. From everything that we just talked, is there anything else that you want to mention? I don't know, about the mechanisms, the flow limitations or arterial desiccation, anything else that you think it's important to mention to the audience?
I think my main message would be, as I've already said, is to listen to the patients, and as I've said, my colleague would say, and then really drill them or do them to death questions wise, to get to the bottom of what might be happening. And if a patient's describing things that are actually puzzling you, probably doubt your own knowledge before you doubt the patient. That would be my key advice with this. And then if you're not sure, go and ask some colleagues, go and read some books, go and read some papers. That would be my advice. And that's really what I had to do, because at the beginning of this process, I wouldn't have believed that I was seeing a 31-year or 2-year-old professional athlete with a vascular problem, because it wasn't even anywhere near my clinical reasoning at that time, and I had to go away and learn, and it's been quite a journey over time. So I think the main message is listen to the patients. I think in terms of mechanisms, I think what you can do is go and look at some of those papers that we've discussed today. There's some quite nice papers out there describing these different mechanisms, and it'll make a lot more sense to you once you realise that a blood vessel can either be pathological, it can have atherosclerosis, it can have, in the lower limb, it can have endofibrosis causing narrowing, or it can be perfectly healthy, and then there can be a mechanical reason why that blood vessel is affected, and that can relate to movement and or combinations of movement or effort. And don't forget that the blood vessels will steal from each other, and that's why we have things like steal syndrome is where one blood vessel steals some flow from another one, and that's the classic thing, the subclavian steal syndrome. The patients get their vertebral artery symptoms because when the arm is required to do something, the arm wants more blood flow, and then it starts to steal it out of the vertebral arteries, and that's why the patients have these unusual vertebral artery symptoms around that time. So don't forget the vascular system is very clever and can manifest in lots of different ways. So I think that's the main message, really.
If people want to read more about that paper had a lot of details, about different mechanisms, and it's very interesting.
Yes, I mean, my go-to places, I suppose, I'm biased because I wrote them, but would be the cranial nerves one, the guide for clinicians, because that's written for clinicians, and it's meant to be really straightforward and explain it in simple terms. It's not meant to be a sort of difficult scientific paper. And the one about the mechanisms of blood flow limitations, that just gives you a range of different examples of how this works, and it just starts to get you into the zone in how you might think about it and how you might incorporate it into your clinical reasoning.
Yep. Any other resource that you recommend if people want to learn more about this topic?
At the moment, the resource, I mean, there's a new edition of Greg Greaves' 5th edition, Musculoskeletal Practice, or whatever they call that. That's a really nice book. I've just started reading some of the other chapters that aren't vascular, and that's a really nice book, up-to-date book, as up-to-date as books can be. And there are some vascular chapters in there, but there's lots of other really good stuff. But as much as Twitter's become, or X as it's now called, has become a terrible place to be at the moment, it's still a reasonable resource for lots of these things. So I still keep an eye on. I can't call it anything else but Twitter. It's Twitter to me still. I still keep an eye on that because often you will find something that crops up on there. And the good thing about that is it keeps you right up to date, because all the new papers get quoted on there, and you might just spot something that's really new, and it sort of changes your ideas about things. So, as bad as that platform is at the moment, I think it's still worthwhile just keeping one eye open for new things on there. But no, I think we've discussed the papers that would. The other place to go, and this is the place I went, is not just the physiotherapy stuff. Is if you're interested in the vascular side, go and look at some of the vascular papers that are out there, the journals that are written by the vascular surgeons. So there's masses written on these blood flow limitations, and by the vascular teams that operate on them. So that's where I found or discover most of my knowledge. So I don't just look at physiotherapy papers. I go out and look at the vascular papers as well. And there's lots of good stuff out there. So if you've heard about, let's say, endofibrosis, and you're not quite sure what that is, if you just do a simple internet search on that, you'll find lots and lots of stuff. And most of it's written by doctors and vascular surgeons, and that would be the go-to place there, because they can go into sometimes too much detail, but it's interesting to see what it looks like from their side. And the other thing is, I think that's why we should be using the same medical terminology as the doctors and the medics use. So I think if they refer to vascular flow limitations, and that's why we've really adopted that terminology, because that fits with them. And if you're going to be talking to doctors and referring patients on, then it's better if you speak in their language.
Yeah, great. And what would be one advice to give to clinicians that are starting their careers?
Keep an open mind. Always listen to your patients and keep learning. It never stops. It never, ever stops. You'll learn something new every single day. And enjoy the job, because it's a great job. You'll learn some fantastic things and you'll help lots of people.
Yeah, very true. Alan, if people want to learn more about you or your work, where they can find you?
On Twitter or X is probably the easiest place to find me. And I think if you can put the details of my blog in at the end of the podcast, that would be a good place. And if anybody wanted to email me, they can find me at the University of Nottingham.
Okay, perfect.
I do occasionally field questions from clinicians, and also I field lots of questions from patients. Well, I often get patients who've been going round and round in circles, and they go, "Oh, I need to talk to you. You're the man who knows about this." And I'm going, "Oh, really? Do I?" Sometimes I can help them, sometimes I can't.
Yeah. Well, you are the expert in the area.
I'm always wary of experts. Yeah, I've got a little bit of knowledge of this area.
Alan, thank you so much for taking the time to come share your knowledge with us and help us be better clinicians. I appreciate it.
No, it's been a pleasure. It's been nice to talk to you, Mariana. Thank you for having me on the podcast.